Hello and welcome to the pod. I'm Nathan Fink.
I'm Jolyn Drennan, and this is New Hampshire Family Now,
a show about building family in the Granite State. Today in the show, we have Dr. Cassie Yackley, Director of the Center for Trauma Responsive Practice Change. Jolyn, she's kind of a big deal, so just go easy with the fangirl stuff.
You're a fangirl.
I'm so excited. New Hampshire Family Now is brought to you by the New Hampshire Charitable Foundation. Since 1962, the Charitable Foundation has worked hand in hand with generous and visionary citizens to maximize the power of giving and support, collaborate, and lead innovative initiatives. Initiatives like New Hampshire Tomorrow, which is focused on making sure children and families have access to education, healthcare, and career pathways to ensure every family member thrives. To learn more about New Hampshire Charitable Foundation and all their initiatives, go to www.nhcf.org. I'm pleased to welcome Dr. Cassie Yackley, Director of the Center for Trauma Responsive Practice Change. Cassie, thanks for coming on the show.
Thanks so much for having me.
I have to say, your name has been coming up about once a week with the wonderful work you're doing. Can you tell me a little bit about the Center for Trauma Responsive Practice Change?
Yeah, I would be happy to do so. And really an extension of work that I and my associates have been building over a number of years, and really came from a lot of my experience in community mental health and working with child welfare and police departments, and recognizing really the growing need to address trauma responsive practices given what we've experienced. And so the center, the general purpose is to be there to provide the very specific training across systems in how to be trauma responsive. And for me, that means really understanding that everybody has a story that's really important to how they function in the world day in and day out. And so how do we work across systems and across providers together to have a frame and a lens that helps people to experience post-traumatic growth? And that's really what we're focused on.
And what defines trauma? Are there different levels of acuity of trauma and the traumatic experience?
Right, because not all adversity is traumatic. And when I've been talking with folks, I think there's a continuum from mild stress to what we know to be toxic stress, right? Chronic, unrelenting stress that begins to have an impact on our well-being, emotional and physical well-being. We all have different response to stress, and a lot of that depends on what our previous experiences have been, right? That if our lives have had unrelenting stress, if the social determinants of health, right, if the quality of supports around me are poor, then I can be more vulnerable to stress. But when we talk about trauma, we're talking both about the exposure, the experience someone has, but also the impact. And so we can have mild distress as a result of something adverse that happens in our lives, or we can develop more significant distress symptoms, which we call PTSD, or post-traumatic stress disorder. And so it really depends. And what makes me hopeful today, to be honest, is that when we understand that, and when we begin to have these conversations about how to support each other and recognize those circumstances, a tremendous amount of growth happens.
Yeah, and obviously individual growth too, but it seems like systems growth is happening as well, right? How is that response of a system going to positively affect outcomes or negatively affect outcomes if you are not aware of traumatic background?
So if I could walk into it this way, I just was with a large group of professionals in healthcare earlier this morning. And what we were talking about, both their concerns as we were talking about what's happened before, but also about what that means for how their organizations function. And so you can look at what happens in terms of being traumatized or experiencing a lot of adversity and what that means for one's personal functioning. But we know, right, that through emotion contagion, through the resonating of our emotions with one another, that our interactions with each other can have that same kind of contagion effect, right? We can feel those same things. And by extension, what I think about all the time right now, you guys, is about our organizations, and especially the organizations of human services that have had so many years of being taxed and being burned out, and then this prolonged chronic crisis that everybody's been experiencing. And so I think much less these days about self-care and much more about how are we going to build relationships within organizations that take care of each other, because trauma-informed care isn't just about treating people different, right? It's working with people in different ways. And we can only do that if we're healthy and we're in settings that are healthy themselves. And it's not a static process, right? Trauma-informed is not a set of knowledge. It's about understanding that we have to always be thoughtful and reflective about what the adversity in the world means for who we are and how we interact and what our systems are doing. And that is the crux of trauma-informed.
I know you're doing a lot of work with the school districts. And so I'm just wondering, how does trauma affect like brain and memory and then learning?
I've been really honored that I've had an opportunity to work for the last 5 years with the Department of Education Office of Student Wellness. Through that, I ran a project. I was the director of a project called GROW, Generating Resilience, Outcomes, and Wellness, where we worked with 6 school districts across the state over this period of time to both assess where they're at in terms of their practices around trauma, also to make changes across 5 domains to the way they intervene with students. But coming back to why schools were the starting place so many years ago that we did this implementation is that we know from the ACEs study and much more research beyond that stress and trauma, again, coming back to the full continuum, inhibits our ability to use our brain fully. And when it happens early, it inhibits our brain's ability to develop fully. And they refer to that through the ACEs as disrupted neurodevelopment, right? So when things are going on and we're very young, when most of our brain grows from 0 to 3, then it interrupts the development, not only of those bottom regions, our ability to control our body and space, our ability to control our hunger and our arousal level. It begins to impact the development of things like our limbic system, our emotions, and our ability to relate to other people. And it begins to interrupt the next piece, which is really our prefrontal cortex, right? Our ability to think abstractly, to think over time, to analyze things and learn from the past. And so what's true is if you have a lot of stress or trauma at any point in your life, but certainly when you're very young, your bottom part of your brain is quite preoccupied and it can become overdeveloped in a way of looking for danger or safety, while it doesn't set the neuronal scaffolding, right, for the other social, emotional, and cognitive skills that we expect to develop. And when those things don't happen, right, when the world's not going right, and when we don't have appropriate neurodevelopment to control our impulses and make decisions, and we don't develop social, emotional, and cognitive skills, what tends to happen, sadly, in our world is people don't want to be around you. And I don't want to be mean, but they are behaviors that are misunderstood. And then we rob people of what we all know is needed, the presence of at least one supportive relationship. So all of those things going on, if they happen over a long period of time, it keeps the thinking part of the brain, the last part to develop, the prefrontal cortex, offline, executive function, as we talked about. And as Bruce Perry will say, when we are in a certain state, right, for a long period of time, those can become traits. They become wired into automatic ways of interacting. So when I'm working with schools, when we're working with a lot of systems, it's really recognizing those impacts, neurocognitively, neurosocially, all of those impacts, and then interacting in a way that says, A, I understand what you've experienced and I'm willing to talk about it. B, I believe you still have all the possibility in the world and that post-traumatic growth is just as much a part of trauma as anything else.
So when trauma does happen, what interventions are out there so to essentially help folks enter that space that is post-traumatic growth?
So I want to talk about a particular intervention, but I want to say this before I go into that. Not everybody's a therapist. But every relationship and any interaction has the opportunity to be therapeutic. And I believe in my heart of hearts that as we move together as communities and families, that's what we all need to remember together. And there are times when adversity has been so significant, when systemic oppression has played out for so many generations that people are in the most challenging circumstances with their children. And I'm talking about folks that often can get involved with child welfare and those kinds of things. And about 15 years ago, I was introduced to a gold standard evidence-based practice called child-parent psychotherapy, or CPP, practiced across the world and the nation. And since I learned that model, I've become incredibly committed to making sure the families in New Hampshire have availability to this really powerful intervention. And very basically speaking, what we believe in CPP is that the caregiver is the most important person in a child's life. And we have to work with both that caregiver and that child to understand their story and to make sense of their story and to grow and heal together. So at this point, there are 24 agencies across New Hampshire and 96 mental health clinicians that practice. We're beginning a new training cohort this fall, hopefully moving forward. Basically, any region you can reach CPP or child-parent psychotherapy. You can also go to the national website where there's incredible resources for supporting young children who are traumatized. And as I look at the crisis we all face together in front of us, right? The mental health needs that are in front of us, the struggles all of our families have been experiencing. I understand the desire and the response to intervene in crises, but we have to remember that early makes a difference, and working with caregivers make a difference. And so I think as we move forward, thinking about, the birth to 8 population and making sure that they have accessibility to resources, including child-parent psychotherapy, caregivers deserve to understand their own history as it relates to their relationship with their child, right? To heal and to atone for what their family has experienced. And I find when we do CPP, we erode the stigma associated with adversity and the distress associated with that. We empower caregivers to take the rightful place of care for their children. And again, then to simultaneously heal from the experiences that they have also had. And there are public health ways we can do this too. I want to mention a school-based intervention that's going to be coming. There's already a little bit of this that will be coming more to New Hampshire for those folks who have the opportunity to see the documentary Resilience. So they, in that, chronicle or describe a particular model called Miss Kendra's program that was implemented or initiated in New Haven, Connecticut, where mental health clinicians partner with school-based folks, classroom teachers and school counselors, and they bring to students beginning in elementary school, kindergarten, and moving up, and also to their caregivers, lessons around our expectations for safety in this world that all caregivers and children should have. Children shouldn't be punched or kicked. Children shouldn't be touched in their privates. Children shouldn't be left alone for long periods of time. And then in addition to that, we equip people with the opportunity to write letters, write about that experience, to respond, for parents to respond and get red beads of courage to talk about the worries that they've faced as well. And they know from the research that programs like Miss Kendra can reduce behavior problems by 75% in a classroom, right? Because we're talking about. So I think about a couple of different interventions where we're reaching both intense populations, but also more primary tier 1, if you want, interventions in classrooms and schools. And I think the center is thinking about all those layers and how stress and trauma, the line that it weaves through all of those systems in that process. I've thought a lot about you all at New Hampshire Children's Trust and the importance of us connecting and collaborating. And I love the idea of thinking how to connect more families to this really. And I focused on child welfare, but I'm going to be really honest with you. As a parent of a child, when I think about intervening with young children, there really isn't anything else out there right now that I think is as good a match for helping parents and children feel connected, helping them talk about, again, the challenges that we all have, and especially the last year and a half, given the pandemic.
We'll take a short break, but when we come back, more with Dr. Cassie Yackley. Don't go anywhere. This podcast was brought to you by Nixon Peabody, who delivers exceptional legal services for clients in the community by combining high performance, an entrepreneurial spirit, deep engagement, and an unwavering commitment to a culture of collaboration, diversity, and humanity. Nixon Peabody works with universities, hospitals, and nonprofits of every size to maximize impact. For more information, visit nixonpeabody.com. Today's show was also brought to you by the Children's Hospital at Dartmouth-Hitchcock and the Child Advocacy and Protection Program, a multidisciplinary program with the Children's Hospital established to evaluate and provide integrative care to suspected victims of child maltreatment. Together, a team of physicians, advanced practice registered nurses, social workers, nurses, and child life specialists work to provide consultation and evaluations of children who are suspected victims of abuse, so to serve in the best interest of children and families at multiple levels of prevention. For For more information about Children's Hospital at Dartmouth-Hitchcock and the Child Advocacy Protection Program, visit www.chadkids.org/child-advocacy. And now back to our interview with Dr. Cassie Yackley.
Cassie, is that training, is the certification, do you have to have a certain level of credentials, or can that be, is there a version of that training that can be given to providers?
You know, I get asked that question a lot because there's so much adaptability from what we take and from CPP and how I use it. And in fact, when I'm working across those settings, I'm often training people in the trauma responsive framework, which is a bit of a modification, if you will, of some of the primary things I've learned in CPP. That being said, it's pretty rigorous to become a trainer. And so I have so much respect for the people in New Hampshire that have worked so hard for this. It's a national certification process. I'm one of 58 national trainers in US. And so they have to be conducted by somebody who's certified by the National Center, which is at the University of California, San Francisco. They go through what's called a rostering process. It takes 18 months of training. They must first possess a master's degree and be license eligible. They have 7 full days of training, bi-monthly consultation, and must see 4 clients within that 1.5-year period in order to be rostered. And then there's also very extensive fidelity rubrics, right? Guides for how they're practicing to make sure they're staying true to that practice. And so fortunately, we've had support from the Endowment for Health and the Children's Health Foundation and other folks to try to support this. I will mention also, as DCYF is looking forward, it is one of the 5 models that they'll be supporting and bringing in to support families as well. So I think more to come just in terms of how we think of that. But if people want to know where to locate someone, again, you can go to the Child Parent Psychotherapy website nationally, and they list anybody in the nation who's rostered. So you can see our folks here in New Hampshire as well as any place else across the country.
Yeah. As you know, much of the work that we do is in that primary prevention sphere, right? And I was taken by something you'd said earlier, that understanding a child's story is critically important, and that parents are the most important person in that child's life. And that while every relationship, I'm not a psychotherapist, Jolene's not either, we both have kids, every relationship has the potential to be therapeutic and positive. How do parents look at this conversation and embrace trauma-informed parenting? Is there something that parents can do and think as they're rearing their children that participates in this line of thinking that's positive?
Yeah, what a beautiful question, because trauma-informed care is much more about how we are as humans, right? And I think I get more comments from people about who they are as parents than probably any other thing. And I hope I've been a better parent because of my experiences with CPP and trauma-informed care. And so what I would say right at the outset is listen more than we talk. I think we all have to look at the myth we have in society about talking about bad things, that it makes it worse. And we learn this with suicide, but we're still afraid with trauma that if we mention it, if we speak the unspeakable with our children, they'll become overwhelmed or dysregulated or distressed, or will say something they weren't aware of. But our children are aware. They do absorb, as we've talked about, both the emotions we have, but also the experiences around them. They make their own story, whether we believe that or not. And so the beautiful opportunity we get with our children is to share that story, to invite their perspectives, to be okay that it might feel upsetting for them to be upset. But our job isn't to help our kids not be upset. It's to let them know that they're not alone when they are. And that's what trauma informs about, right? Like, things aren't always going to be okay. And life inevitably involves a lot of loss. And so how do we help each other recognize that has happened? And I also have to not blame myself as a caregiver. And that's trauma-informed too, right? That we do the best we can given our circumstances. And that's what CPP is also about, understanding. Whoever you were as a parent, whatever your experience had been, we can understand those. And when you understand those, you don't repeat those same things with your child. And that can be maltreatment. It can be you and I, right? You guys and our kids, and thinking about how my teenager is now, we're going to start the dynamic that my mom and I did when I was a teenager. How do we not do these things as parents is kind of the game.
Yeah, I feel like I'm still my son's child at this point.
Maybe that's how it always is. Let's be honest.
My husband and I, anytime we get into, like just an argument or anything in front of my son, he has, the social emotional learning that's going on in the public schools is like, it's so effective because he will tell us, he'll be like, Mommy, Daddy, you guys need to talk it out.
Jolyn, that means I am in no danger of adopting some alpacas at this point.
Someday I'll tell you more about my pony in the backyard.
In light of traumatic experience and adverse childhood experiences, which a lot of people refer to as ACEs, can you tell me a little bit about what ACEs are, why they're significant, and how we identify them so we can steer kids in the right direction?
Absolutely. So ACEs, adverse childhood experiences, in some ways can be used, interchangeably with the word trauma, but it's really based on a seminal study that was conducted in the mid-90s by two researchers, Anda and Valetti, who were medical researchers working for Kaiser Permanente. And they were really looking around medical issues around obesity. And they conducted a study with 17,000 middle-class Americans, primarily white, that were receiving Kaiser Permanente. They did three things in the study. They asked them about ACEs, adverse childhood experiences. And for the sake of the study, there was a list of 10. And arguably, there are far more than 10 funny things that could happen to a child or a family by that period of time. But again, they represented the four kinds of child maltreatment, things like parental incarceration, loss of a caregiver, etc. That was the first source of data. The second source is they asked them about their behaviors, primarily around substance use and relationships. And then last but not least, it's a medical setting, so they were able to look at their physical condition, both at that time, historically and longitudinally, or moving forward over time. When they looked at the combination of people's adversity and behaviors, psychosocial behaviors, and their medical health conditions, we learned a couple of things. We learned that 65% of citizens experienced some kind of ACE or adverse childhood experience prior to the age of 18, and those things cluster together. We'll be familiar. Multiple things will happen, adversities. And so once you jump into that category where, yes, I've had one ACE or adverse childhood experience, about 65 to 70% of folks will say, yes, I've had 4 or more of those adversities.
That is startling. And when I think back to what you had just said, a study of physical health would indicate that predictably something that happens to you, and this is obvious now in retrospect, but something that happens to you is more impactful than something that you do and choose to do or are doing. Because when I think about my own rearing, it was all the avoidance and taking responsibility for not making certain choices. From a physical study, there's something here that's more impactful than your own decisions that may control the decisions or influence the decisions you make.
Yeah. And then they were able to make associations with the primary health conditions, chronic health conditions, diabetes, heart disease, et cetera, cancer, et cetera, and find out that ACEs account for the vast majority of the statistical amount of that, far more than things like smoking cigarettes and getting lung cancer, et cetera. And since that time, I mean, that's one study, but it's really compelling because it's been replicated, right? Over hundreds of thousands of individuals in every single state now. And we know that those numbers bear true. But I want to add one other thing about ACEs while we're talking about it, is I've seen a lot of people jump on the trauma-informed bandwagon a little bit. And it's an important movement, but I want it to be lasting. It's the plate. It's not a temporary thing on the plate. And so I do hear a lot of settings trying to figure out how to ask about ACEs, how to see ACEs and determine that. And what I would say now is we know that using a cumulative ACEs score, asking people to simply give a number between 1 and 10 of those things they've experienced doesn't work for 2 reasons. Number one, we don't allow people to share their experiences, which is part of what produces post-traumatic growth. And number two, some of the newer research from the Harvard Developing Child out of that shop shows us that particular kinds of ACEs have synergistic impacts, right? Exponentially worse when they're combined with each other. And I would be remiss if I didn't make one mention of child sexual abuse on this. And I know that's a very difficult topic for us all to talk about, but it is one of the things in any form that causes much more substantial potentially impacts when sexual abuse of a child is combined with any other form of abuse.
But trauma does happen. A child may experience car accident, fire, or maybe they're witness to domestic violence. Are there interventions available within the community to support a child or a family after experiencing a traumatic event?
Yeah. So in addition to some of the things like child-parent psychotherapy that we talked about, you think about how can we intervene early and when people are in the midst of crisis and most in need. And we've had through Amoskeag Health a really beautiful program that's flourished across the state that I've been lucky enough to be involved with. That also looks like it could happen more on the national level. They've been forming what are called ACERT teams, which stand for ACEs response teams, but they're based on the understanding that we need to partner across police departments with other mental health providers, but also to provide a liaison to families in situations where the police are involved and they need supports, referrals, either to a crisis center or to very direct concrete needs. Often these referrals from the ACERT teams, the ACEs response teams, are to child-parent psychotherapy or one of the community mental health centers or available services that are out there in the community. So it's a way of thinking about how we can do more warm handoffs, how we can support families better across our systems. You mentioned earlier being so fragmented. And I think ACERT and these kinds of things are a way for us to be together more frequently and to refer more frequently to each other so families don't have to make the linkages for themselves. And so all of those ACERT teams undergo a period or a training around trauma responsive policing that I provide for them as a foundation, which again happens with a lot of other community partners so that we're all having that same lens to intervention. And Manchester and Amoskeag Health in particular serve as the kind of the technical assistance center for that work in particular. But the other places that have been established, I'm going to feel bad if I miss any of you guys, but Concord, Franklin, Laconia, Somersworth, Nashua, Claremont, I might be missing one. Pretty good spread right now. And they look differently. It depends on where they're at. If you think about Nashua and the way they're intervening, their partner is in substance abuse and recovery-oriented services, and those are the linkages that are being made. In other communities, there's strong linkages like with Upreach, the equestrian therapy center. So some of the linkages get made to those and other kind of alternative services that might be available. So in each community, it looks a little different depending on who the partners are and what those linkages are. And if you don't have connection, you need other people, right? This is this healing part again and again. When you hear people that keep telling their story, this is why, right? I need to put words and meaning to my experiences. I want to make sure that I share one last story with you guys that for me is just deeply meaningful and really epitomizes what we've been talking about today. It happened a number of years ago. And so I've talked about it hundreds of times when I present. It's usually right at the beginning to warm people up to what we're going to talk about. And I share a story that I was way up in rural Maine, in very impoverished Maine, and I had a full day opportunity to present to a school district. There were probably 75 people there, something like that. And I've been a therapist my whole life. I'll tell you, a teacher came in and a guy came in, and I was worried. This was really early on. I was worried about what I talk about. I was worried about re-traumatizing somebody, saying something's upsetting or playing the videos I play that are upsetting. And so I thought about it all day, but I also know this information is really important. So I do the whole day, right? The end of the day, people are chit-chatting. This guy waits about 45 minutes. He's in the way back of the room, standing at the back of the room. He waits till every single person leaves. When they leave, he comes up to me. He's a big, gruff guy. He's got his arms crossed. He gets right up in front of me and he says, "You need to know something. I didn't think I was going to make it through today." And there are a lot of times I almost got up and walked out. And I will tell you, as a presenter and a trauma person, my heart sank. That's the last thing I'd ever want to do, right? My worst nightmare. But what happened next is amazing. He looks at me, right? It's no joke, you guys. He gets all teared up and he says to me, "Thank you. Thank you for talking about those things." And then he started to cry and he said to me, "You know what I thought all day? Why didn't anybody ask? Why didn't anybody ask?" And I think that's really important. If I can just share a very quick follow-up. 2 years later, I was up in Maine again, go figure. My husband was with me, who is a school counselor. And I say to him, "I'm not going to tell that story anymore. I've told it hundreds of times every single time." He said, "Well, you're in Maine. You should do it one more time." Okay, so I do it again. I don't recognize anybody, right? I give the whole presentation and not 10 seconds after I get done, guess who walks up to me? I told this story. I haven't told this in a while. I told the story exactly like that. So I say first, this is pre-COVID, right? The first thing I say is, oh my gosh. Oh no, he says to me, well, I'm not going to make you wait 45 minutes today. Thank you so much. And so then I said, can I give you a hug? He said, yes. I gave him a big hug. And then I stood back and I looked at him so moved and said, oh my gosh, do you know how many thousands of people have heard your story and are going to ask kids about their experiences because of you? Thank you for your courage.
Cassie, I think I'm in love with you. It's been an absolute pleasure having you on the show today. Thank you so much. Please come back in the future.
Thank you so very much for this opportunity to talk to your audience. I would welcome any opportunity to do it again.
To learn more about trauma responsive practice change, go to www.centerfortrpchange.org. Many thanks to New Hampshire's Office of Social and Emotional Wellness for sponsoring this podcast. Started within New Hampshire's Department of Education, the Office of Social and Emotional Wellness consolidates policy development and implements projects and programs that are focused on health and wellness with an emphasis on behavioral health of all students, youth, and families. To learn more about the Department of Education and its many programs and approaches, visit www.education.nh.gov. New Hampshire Family Now is listed on Apple Podcasts, Spotify, Google Podcasts, Amazon Music, Stitcher, iHeartRadio, and more. Listen wherever you get your podcasts or ask your smart speaker to play New Hampshire Family Now.